So, first of all, it's a great privilege to be here in front of you all at the same place where I uh, thrived as a medical student, where I started my clinical career as a third year clinical student. So, okay, and then I'm so grateful for the all the officials of KSM who offered me the opportunity to make this talk. And uh, I thought of talking through something which is very relevant, which is actually one of the most common gynecological issues that we encounter. So let's start. So basically, the lecture I'm going to like present to you is I'm not going to detail into the management because it is a huge topic. It has like very vast array of things that we encounter, but my objective is particularly for the medical students and GPs and also the other doctors. I really want you to not to miss the danger, and then realize the even the minor things sometimes really matters. So I thought of giving you an overall idea about how to evaluate and to properly refer a patient to a specialist. So that's the idea. So each and every individual situations, the management actually you can if you're really interested, you can go through, or we can talk about it later on in another day. Okay, so the problem is, if we encounter abnormal uterine bleeding, sometimes we call it like irregular bleeding and various names, but the problem is, can we miss this? No. This is a specimen on table of endometrial carcinoma. When we open it up, it juts out like that. So you can't miss it, because if you miss it, the ultimate outcome will be devastating, right? So my talk is basically based on FIGO, that is the Federation of International Obstetricians and Gynecologists. The guidelines, they have revised, and they have gave a new classification and nomenclature. So we'll follow that to talk about these in a different way, right? So this is one of the recent referrals that I have received from one of the general practitioners. So please see this 41-year-old lady come with heavy periods and do the needful. So is this adequate? I don't think so, right? So we'll come to the proper topic. What is the definition of abnormal uterine bleeding? It's a uterine bleeding of abnormal quantity, duration, or schedule, right? So we had set of definitions that we used to talk, but still I think we do talk about it. We call menorrhagia for heavy menstrual bleeding, and metrorrhagia, menometrorrhagia, oligomenorrhea. All these terms are now should not be in use, because when it comes to research, you gather when you do a proper literature survey, these things come with various like a vast array of mistakes, with lot of mistakes, because someone's menorrhagia may not be the same menorrhagia that someone else is describing. So instead of that, FIGO decided, okay, we'll go to a set of clear definitions that even a lay person can describe in their own language, right? So I'll come to that later. Right? Why this is crucial? Why are we worried about this bleeding? Right? Main cause of iron deficiency anemia in women is most of the time undiagnosed heavy bleeding, and it is common across all age group, starting from teenagers to the post-menopausal bleeding. You have various etiologies and factors that affects, and it affects about 30% of all women at some point of their life, and up to 30% of all visits to a gynecologist is because of abnormal uterine bleeding. So it's one third, right? And even in developed countries, only about half of those affect seeds care, because they either ignore it, or they don't think that this is abnormal. So think like country like us, definitely the numbers are higher. So either they come with a advanced stage malignancy, or either they come with after collapse with anemia. And many who seek care are not satisfied, even though we have a wide array of treatment methods. They're not satisfied with the treatment. Right. So what is normal uterine bleeding? So this is what FIGO declared. So sorry for I think you can see it. So they have come under six categories. How to describe a period or a bleeding. So if you have bleeding less than if you don't have bleeding, I mean if you miss a period from that point onwards, you call it amenorrhea, right? That term is still there. And then if you have periods coming lesser than 24 days, you call it frequent periods. If it's more than 38 days, you call it uh, infrequent periods, right? And then if you talk about the duration, if you have lesser than 8 days of bleeding, that's all right. But if it's more than 8 days, you call it prolonged bleeding, right? And then when it comes to flow, now those days we call it like this many milliliters, this many pads per day, and likewise. But it is not now. If you have undisturbed period at some point of your life, and now you are having heavier than that, we call it heavy. That's it, right? And then you have intermenstrual bleeding. That means you have scheduled bleeding happening, scheduled menstruation is happening, but in between you get some bleeds, right? It could be random or it could be cyclical. And then you can have this unscheduled bleeding, which happens to people who take some form of hormonal medication. Because when you take a contraceptive pill or any other hormonal medication, you know that you are scheduled a bleed, right? You're scheduled to bleed, right? But if it's not, if you're bleeding in between, so you call it unscheduled bleed. So now if you get a patient, you can call this patient is having frequent, regular, heavy bleeding, or infrequent, regular, or irregular, heavy bleeding. Oh, this patient is amenorrhea. You understand, right? So it's not like menorrhagia, metrorrhagia. It's now very easy to understand and very easy to describe, and everybody is in the same shoe on that, right? Bit of physiology and pharmacology, you know what this is, and this basal layer of the endometrium, which gives rise to the functional layer. The functional layer is the one who gets sloughed off at every periods, right? And these two part of your periods are like menstrual cycle is very important, because at the end of menstrual cycle, you know that corpus luteum converts into corpus albicans, and there is a sudden drop of estrogen and progesterone levels. You get this withdrawal trigger of inflammatory process. With the inflammatory process, leukocytes come in play. All these enzymes will degrade the functionalis layer, and you start bleeding, right? At the same time, when you start a new cycle, a new follicle growth will give rise to another, basically estrogen will reepithelialize the endometrium. So when the reepithelialization happens, the broken vessels covers up, as well as prostaglandins that release will squeeze the myometrium. So interdigitating vessels will collapse. So bleeding stops. So this is what usually happens and should happen, right? Okay, let's classify this the particular etiologies that we are going to talk. Whatever it is, first you have two questions always need to ask. If someone's come with a vaginal bleeding, make sure if that lady is in reproductive age group, exclude a pregnancy, because the problem may be not gynecological, it may be early pregnancy, right? If you miss it, it's again a huge problem, right? Then the next question is, are you dealing actually with uterine bleeding? Because sometimes you can have a kind of vaginal infection, or maybe a coital tear, or like a trauma, you can have bleed, right? It is not uterine bleeding. And especially among these all ladies, who are bed bound and then with wearing adult diapers and stuff, you see blood in diaper, but it is not most of the time vaginal. It could be rectal bleed, or it could be bleeding through urethra. So first you exclude those things before coming to discuss about uterine bleeding, right? Sorry. Okay, so this is the classification, which is very easy. If you go through this, you will not miss things. Palm and coin, right? PALM is structural causes. So this is the classification given by FIGO. So it's P for polyp, A for adenomyosis, L for leiomyoma, which is fibroid, M for malignancies and hyperplasia, C for coagulopathy. They are like functional reasons, non-structural. So coagulopathy, ovarian dysfunction, E for endometrial issues, and I iatrogenic, that things that we create, and there are few things that comes under none otherwise classified, right? So polyps. So these two images I have taken when I was a senior registrar at Ward 5 in this hospital. So this is a hysteroscopic of polyp here, and then the previous day we usually do when we suspect a polyp, we usually do a saline sonography. Here you like insert a gauge 8 urinary catheter. This is the catheter bulb. You instill saline, so you can nicely visualize this polyp, so you know what you are dealing with following day surgery, right? So polyps is quite common. Clinical features usually you get is can have heavy bleeding because of the surface area, intermenstrual bleeding, postcoital bleeding, and because of the glandular nature of this polyp, you can have more vaginal discharge. Unless it comes out like this through the cervix, you might not see any clinical examination features, but surely with ultrasound and saline infusion sonography, you can visualize polyps. And to diagnose and remove it, the gold standard is hysteroscopy. So you can, if you diagnose a patient with a polyp, you can definitely refer the patient to a gynecologist. Where if you have hysteroscopic facilities, it's incredible. These things you cannot miss. Malignant predictors of a polyp. So if you have new onset of a symptoms with more than, suddenly you do a scan and you found a more than 10 millimeter polyp, long story short, it's a fast growing, right? So that's not good. So if you get one, you should refer. And someone who's having who's in post, like who reach postmenopause, and then she's also, if you see a polyp and a bleed, surely she need to be evaluated. Rather than asymptomatic polyp, obviously a polyp with bleeding, because it bleeds when it necroses. So necrosis, the chances of necrosis is high when it's malignant. So if it bleeds, there is a potential of being a malignancy. And even if it's asymptomatic, if the diameters are very high, like 18 millimeters or 20 millimeters, it's significant, right? Okay, so then to adenomyosis, so which is presence of functional endometrial glands within the myometrium, right? So it's, can you imagine, you have a muscle in, and then you have a bleeding every month inside that muscle, how painful it could be, right? It's the same. You have smooth muscles in the myometrium, and she is bleeding within that muscle, right? So they get severe dysmenorrhea, right? So with this, it gets larger, and that muscle will not contract properly, so you bleed. The process of ceasing bleeding will not happen. So she started continuously bleeding, the bleed will be heavier, so they get heavy menstrual bleeding, and also the uterus is boggy and tender, so they definitely get dyspareunia as well, that is pain while you have sexual intercourse. And on examination, you sometimes feel that very boggy, regular, like big uterus. And this is common among, like, if you get a patient as a GP, it's common among like age group of 40 to 50s, and particularly among Paras women. So there are sometimes coexisting conditions as well, as you can see. So this is a specimen of a adenomatic uterus. Can you see, like, bleeding within the myometrium, and you can diagnose this with ultrasound definitely to a certain degree, as you can see the sensitivity and specificity. But if you are in doubt, or if you need to dig further, you can do MRI, but it's not mandatory. And confirmation of diagnosis is, as you can see, the glandular structures within the myometrium, so it's histopathology, right? All right, so then L is leiomyoma, which is fibroid. This is a real photograph I took recently when I was operating on one patient. So it's a smooth muscle and connective tissue neoplasm, which is hormone dependent. Lifetime risk for a lady to have a fibroid is 30%. So 1 in 3 will carry a fibroid at some point of their life. So there's genetic predisposition is there, overweight, nulliparity are the risk factors. About like sometimes we find fibroids in autopsies because they are not symptomatic, because these fibroids will not cause problems always, but when it comes to problems, it is very nasty. So they are, as I said, hormone dependent. So risk factors are, if you have more estrogen exposure in your life, you have a high risk. So early menarche, you have high risk. Increased BMI, obviously you have high risk. Most of these patients are quite obese because they themselves produce estrogen within adipose tissues, right? And polycystic ovary, again, you're not ovulating, you have growing follicles, which follicles continuously producing estrogen, you have a higher risk. HRT in postmenopausal women, which is hormone replacement therapy, and if you have family history and certain ethnicities, it's very common, right? So this is another very important slide, which is FIGO classification of fibroid types. So we used to say that, this patient is having a fibroid, doesn't mean anything, right? Doesn't sense anything, because if you talk about a fibroid, the other person should understand and have the clinical picture, or the person who's going to operate. If someone's doing the scan and give the information, the person who's going to operate should have the same clinical picture what this person is talking about. So they gave a real nice way of description. So as you can see, fibroids can be various. They can be pedunculated like this, subserosal like this, intramural like this, and sometimes parasitic somewhere else, or can sitting at cervical, again it's parasitic. So they have described in a different way. So if someone's saying you have type 0 4 centimeter fibroid, that means it's a pedunculated submucosal fibroid. You get it? And then if someone says you have a 3 centimeter anterior wall type 1 fibroid, that means 50% of the fibroid is within the cavity and less than 50% within myometrium. 2, it's like more than 50% within myometrium. 3, touching the mucosa, and 4, it's completely within myometrium. Likewise, you have that numbering classification. So you can document that this lady is having this fibroid at anterior wall, which is this size. Everybody knows what it is, right? So these are two of the specimens that I recently operated. This is actually, you can see now, this lady was carrying IUCD here. So this is the cavity. So these fibroids are jutting into the cavity. So she presented with heavy bleeding, right? And this one is a pedunculated, that is type 0 fibroid, which is actually coming out from the cervix to vagina. So she came with a lump at vulva, which was a fibroid coming through the uterus. So you have clinical presentation. As you can see, it is fibroids, as I said, is nasty because you get various clinical presentations with various troubles. You have menstrual problems, you have mass effects because they are sitting on either bladder or the rectum, and you can have reproductive issues and pregnancy issues. So I'll just talk about this. I think this lecture can be accessed by everybody, right? So you can have heavy bleeding because when you have a submucosal fibroid, that is fibroid sitting just underneath the mucosa of the uterus, it increases the surface area, right? As well as the fibroid itself has a huge blood supply. So at each cycle, she will bleed heavily, right? And then because of that, when the uterus start to contract, they get the pain. So they get dysmenorrhea. And if it's sitting somewhere in the pouch of Douglas or cervix, you can have pain when you have sex. Right. So the examination, which is very important, especially for general practitioners, because if a patient comes to you with heavy bleeding, make sure you touch the tummy and examine. You can't miss a palpable fibroid, right? So usually they are enlarged, irregular, or regular maybe structures that you can feel over tummy. And then the usual examination that we do, we try to go below the lump. So if it's arising from the pelvis, usually you can't go below the lump. So that's one of the features that you can tell that this is rising from, most likely from the uterus, right? And sometimes they are maybe immobilized. You can't mobile, like, on your bimanual examination. In these conditions, when you have concurrent endometriosis, there are adhesions, and if she had like previous surgeries or pelvic inflammatory disease, she can have adhesions, or it could be a malignancy, right? So diagnosis, again, you do imaging. They can be hyper or hypoechoic in nature, and in rare instances we order MRI, where sometimes we have to exclude malignancies, right? Especially for general practitioners, again, when you request a scan for a lady who's having a pelvic mass, make sure you go through the entire thing, like not just the features of the mass, because sometimes this mass can sitting on the ureters, so they can get obstruct and can have hydronephrosis like this. So then you refer in a better way that this patient is having a huge mass, which is a fibroid, ultrasonically, and then she's having a complication of hydronephrosis and hydroureter. So we have to do something urgently. I think you can understand what I mean, right? And then also look for the features of a malignancy, where, as you can see, they're large, fast growing, most likely, single, and not like isoechogenic. They are most of the time heterogeneous. They have multiple echogenic patterns within. And if you do the Doppler like this, you get strong vascularity inside. And by the way, if someone's having a fibroid, if they come to you and tell you that I have a fibroid, and doctor scanned and told me, okay, this is not giving you symptoms, no need to remove, can I convert this fibroid into a malignancy? No. If a benign fibroid is there, that's benign. If there's a malignant fibroid or sarcoma is developing, that develops from a new cell. You understand, right? If you have a benign fibroid, it will never convert into a malignancy. So you can reassure, right? And M is the last one in structural malignancies. So all these three types of malignancies can give rise to bleeding. Endometrial cancers and hyperplasia obviously give rise to bleeding because it's within the endometrium. Cervical cancers, okay, again you can have it. Certain ovarian tumors also can give rise to abnormal uterine bleeding, because granulosa cell tumor, which is estrogen producing, grows the endometrium, and then it can bleed. Theca cell tumor or thecomas are the same, right? Huge set of risk factors are there, especially age is one of the things when it comes to endometrial hyperplasia and malignancy. And again, it is estrogen dependent. So most of the time, if you get higher level of estrogen, early menarche, late menopause, and then endometrial hyperplasia, especially with atypical endometrial hyperplasia, you have a higher risk of getting a cancer in future, or sometimes they have concurrent cancer as well. The same thing that I already told, like polycystic ovary syndrome, metabolic syndrome, nulliparity, all these are high risk for endometrial cancer. And then estrogen receptor modulators like tamoxifen, which we give for breast cancers, again has a high risk. So if you have a patient with a breast cancer who's on tamoxifen, make sure she had a ultrasound scan of her uterus at some point to see the endometrium. And in liver disease, your estrogen level rises because of the lack of metabolism. And all these genetic conditions that you can have. And particularly with these cancers, you have a higher risk of concurrent endometrial cancer as well. The appearance in ultrasound, cystic, enlarged endometrium, as you can see. And if you check Doppler, it's highly vascular. The way you biopsy it, you can have like easy methods, office techniques like people biopsy. She comes to you, you can take aspiration. These things actually you can do in general practice as well. And this is a thing that you have to do in theater, which is curate, which is now actually old school. This is the gold standard. You go do a hysteroscopy, find the location of the abnormality, take the focused biopsy. So these are hysteroscopic appearance of various endometrial cancers. So then when it comes to coin, starting coagulopathy, so always when you inquire a patient, ask about these questions. Whether you are having a family history of coagulation diseases, whether are you on any anticoagulants, or do you have these form of conditions which you can have coagulation developments? Because if you don't have a structural cause, one of the most common cause is coagulation disorders. And then what happens is in ovulation dysfunction, it is the coin O. So where you have no ovulation, in particularly, as I said, like anovulation, no oligoovulation in polycystic ovary syndrome, you don't ovulate, so you continuously produce estrogen because the follicle is at the first half of the cycle, continuously produce estrogen that will grow the endometrium, and at some point it will break down and bleed. So it is an unscheduled uterine bleed, right? So causes for AUBO, or the abdominal uterine bleeding ovulatory, reproductive extreme ages of reproduction. You know that early menarche, you usually will not get periods for few times, and then you suddenly get another period which is heavy because they are not ovulating every day, every month. Sorry, and the on the other hand, closer to the menopause also the same thing happens. So you can have unscheduled bleeding. Because so this evidence is basically in 2021, the study done in Gampaha, about like suppose 6.3% of young women have polycystic ovary, but I think if you do it now, it's much higher than that because of the like the changes of lifestyle. And stress, of course, and the poor nutrition can also cause abnormal uterine bleeding because of stress and you know closer to exams, closer to big events, you usually don't get periods for a few months. That's the reason is you're not ovulating, but then suddenly you can have unscheduled bleed. And out of these things, I want to particularly emphasize thyroid diseases. So if you get a patient who's not having a structural cause for abnormal bleeding, always look for hyper or hypothyroid features and examine for that, because that is one of the common causes that you can have abnormal bleeding. So endometrial dysfunction, this is the diseased endometrium. So no structural issue, but endometrium itself is ill. What happens is usually in infections, pelvic inflammatory disease and inflammation, you can have this ill endometrium, right? So the problem is it is not functioning properly. So when it starts bleeding, it bleeds. And then iatrogenic causes. So hormonal contraceptive is one of the things, because we give hormonal contraception like COCP, they take it, but sometimes they take it continuously. Sometimes they get the withdrawal bleed. Sometimes they can have sudden missed pills. So with the missed pills, they can have unscheduled bleed. So this is what happens with hormonal. And on the other hand, copper IUCDs, if you put IUCD, it induces inflammation within the endometrial cavity, so you can have bleed, right? And these are the things that comes on the end, which is not otherwise classified. Caesarean section scar defect, which is called caesarean niche, where there's a small pouch. You get your periods, and the period bleed will accumulate in this, and later on, after a few days after your period, this blood will come out. So it's very troubling, that lady, because she already like finished her period and ready for a fresh day, and again she bleeds. So that's the problem with cesarean sections. And then AV malformations, which is rare but can have mostly either congenital or after the curettage procedure or any intrauterine procedure, you can have AV malformations. And these things are pretty much rare conditions, sarcoidosis. And so this is one of the important slides that I want to emphasize, because when you, as a medical student or a GP, when you're taking a history, just follow this so you will not miss. Always ask about menarche, and then about the time that she had where she didn't have troubled periods, where she like, even like, in your life you have periods that you don't even recall that period, it was fine, you get scheduled bleeding, and then ask to compare that nicer time with current condition. Okay, those days you have used 3 pads, now you are using 5 pads. Those days you didn't have clots, now you have clots. Always get that comparison and see to what degree you are having this trouble, right? That's number one. And the duration. Then along the palm coin, you exclude the etiologies. Like this, you take first polyps. Okay, do you have intermenstrual bleeding? Do you have discharge? Do you have postcoital bleeding? Then go to A, adenomyosis. Do you have pain when you have periods, and do you have passing heavy blood? L, Leiomyoma. Do you have like heaviness in your tummy? Do you have trouble when you pass urine? You have voiding symptoms, whether you have storage symptoms, whether you have constipation. And then you go to M, that is malignancy. Do you have, are you updated with your pap smear? Number one. Number two, do you have any strong family history of those mentioned malignancies? Do you have like very irregular kind of a bleed? And then are there any other high risk for malignancies and constitutional symptoms of malignancies? You can even at the examination also you have to check, right? And then when it comes to coagulation, ask, do you have family history of coagulation disorders? Do you have a disorder which can cause coagulation derangement? Or are you on anticoagulants, right? O, ovulatory. Are you having hirsutism? Are you having acne? Are you having like recent weight gain? So there are features of PCOS. Do you have headaches, vomiting? Do you have any new onset breast discharges? Features of prolactin. Do you have thyroid symptoms? Again, thyroid dysfunction. So if you go through this palm coin, you can like confine set of etiologies and exclude many, right? Then you check whether she's anemic. You ask for anemic symptoms, check hemoglobin. Then always make sure always you assess the quality of life. So whether this is disturbing your sleep, whether this is suppose someone's having adenomyosis and concurrent pelvic pain, they can't sleep. I have seen patients. They sit on their bed all night. And then whether this is affecting your sexual satisfaction and life, whether this is affecting your psychology, whether are you having trouble social life. Of course they are, because sometimes they always have to wear a pad because they don't know when they bleed, right? And then whether this is affecting day-to-day activities of yours. And always ask, what is the management up to now? If you're diagnosing someone at first, that is fine, but otherwise, because if you're not asking that, you may try something that she had already tried, which will not work. Then examination, my suggestion is, especially for general practitioners, if you can keep few speculums at your practice, it's very wise, because you can offer pap smears, you can see those polyps, you can find out cervical lesions, and you can refer. So then it's much easier for a specialist to handle from that point onwards. And if you offer, still we encounter a lot of cervical cancers in our country, even though we have a pap smear service, because we now, suppose being a GP, you always encounter a woman at her age beyond 35. You ask about whether you had a pap smear, say no. Okay, we'll have one today. You can do that, right? That's actually a kind of a life-saving thing. And then investigations, I always request, if someone's not having symptoms of hyper or hypothyroidism, don't offer her TSH. It's a waste, right? So it's always guided investigations that you should offer. That's cost effective one for the patient, as well as it's that is being clinical, right? So this is, I would say, the referral that should have been oh sorry, this is, I would say, the referral that would have been received by myself. So suppose I got this, I'll tell you the story. This patient, I have seen this 41-year-old lady who is a mother of 2 children with regular heavy menstrual bleeding over last 5 months, currently with anemic symptoms. Her contraception method is IUCD. She is updated with cervical screening. At presentation, her hemoglobin was 6.1 gram. On examination, there was a lump. Based on the information, you can offer by, like, when you examine, you feel a lump, you offer an ultrasound scan for, right? So then she got done the scan, and there's a multiple fibroid uterus. Other features like hydronephrosis or hydronephrosis are not there. So please see this patient and discuss the plan and offer the follow-up. So this is the referral that should have been. This was the patient's specimen. the first referral I received for this patient. All right. Thank you very much, and I hope you have like gathered some information to evaluate a patient with abnormal uterine bleeding, which is a big topic. But I just want to emphasize the fact that you don't miss things. If you find out things and if you diagnose, then from that point onwards, it's much easier for a specialist to look after. Right?